And gosh, how many people have already said the relationship? This is really, really important. I think we've really lost sight of the healing power of relationships in mental health services. I'm seeing a few nods around, so I can see that I'm not alone in that. I've watched a number of situations lately where I've seen people left alone while everyone waits for the medication to kick in. People not attempting to engage and connect with people. People not believing that it's possible to engage and connect with someone who's deeply depressed or acutely psychotic, or whatever you want to, whatever language you want to use about that. So, I think that, the other thing is all that talking about people. That slide about the amount of time that young doctors spend in face-to-face time with people, that'd be interesting to do that in mental health as well. I know there have been some studies that show that the average person on an acute inpatient unit would spend 84% of their day not communicating with other people, which is quite high, really. And yet we spend a lot of time as workers talking about people in their absence. And I think that's really something that in a recovery-oriented system has really got to change. Why is that person sitting on their own in their room while 3 professionals or more sit around every morning talking about, gee, I wonder what's going on with them? Why aren't things changing? Shall we try this? Shall we try that? And there is some very good research coming out of Finland at the moment that's showing that involving people in those discussions, talking with people, not about them, is actually promotes people's healing and recovery. So I just wanted to put up this slide because this is a quote from one of our students, and I think that it kind of, to me, epitomises where we're at the moment. It's really hard to see the possibilities when we're looking through our existing lens, yeah? We've got to... It's sort of that idea that we can't solve our problems with the same level of thinking that created them. So we really need to kind of shift our point of view, and one of the main ways that we're going to do that is by doing it with people who've been there. Over to you, Michelle.
She'll be back. She has the last word.
Always.
How could it be otherwise? Oh, that's okay.
No, I'm fine, Corinne. Absolutely fine.
So I was to talk a little bit more about trauma-informed care and our understanding of what the implications would be for the mental health system. We've talked so broadly about this today. I'll keep my section briefer. But our understanding is for the mental health system, that if we understand and implement trauma-informed care broadly, that will be moving... Our initial question about a person who's distressed will move from what's wrong with this person, all the other questions that emerges then, to what's happened to this person. That will be our first question. That'll be our first port of call in mental health services. And for that shift to occur, there's a lot we're going to have to really get. And we've already talked about this today, about not being an add-on, not twittering around the edges, not a workshop here or there, but about a fundamental shift in our understanding of what's led people to either seek or be compelled to receive mental health care. We're really going to have to get the extent of trauma. We've talked a lot about that today, and I'm not having to go through the evidence again with you. And the profound impact of that trauma in the lives of people who are currently receiving mental health services. And the trauma that they experienced in their early lives, as well as the trauma they've experienced in their lives since developing forms of acute distress, the losses that's led to. So having to take that on board and really understand that and get that, the mental health system is going to have to really get that trauma can have direct and tangible links to the present. Taking Deb's quote from a previous presentation, the past is the present for many trauma survivors. Richard and Kathy also talked to this. That it's not background information. I remember they were my first kinds of sets of clinical notes where trauma was background information, and then the first time working with adolescents, thinking, hell, this isn't background, this is 6 months ago. What's it doing in the background section? This is huge, it's present stuff. And the losses and the traumas that people describe. But even for adults, 30 years down, 40 years down the track, the past is the present, it's not background. And that therefore the impact of of working with the impact of trauma is core business for mental health services. In some ways, it's kind of denial and minimisation and kind of compartmentalisation makes sense. It's a bit easier to go, now I've seen there's been a sexual assault, that's for that specialist service. There may be a role for specialist services, absolutely, but understanding and dealing with the impact of trauma probably needs to be core business for mental health services, not carved off to specialists. This is what we do, or what we should be doing. And the harder thing for us to get, I think, and to come to terms with, is that contact with services is sometimes traumatic for people and causes further harm. It's a hard thing to sit with. And when I say services, and we, that includes me, I've been a part of those services and part of those systems. That's harder to sit with that. But in order to provide trauma-informed care, we're going to need to come to terms with that and do something different. So taking a small group of students through a process in this year with a trauma-informed care unit, the time that we've offered this at the Institute. I talked to this student later and she said this is somewhat of an understatement, but absolutely shocking, saddening, distressing. And what we're asking those students then to do, and by extension the mental health workforce, is to come to face with some of their own history as well and see its relevance in their daily lives. And that's a big ask. Some of the other implications, I think, for the workforce and for mental health services should be self-evident, that increased supervision and support and increased attention to well-being of the service as a whole is critical because it has an impact on the person receiving care. Not looking after workers just as an end in itself, but because it makes sense for the whole system to be healthy in order to provide that support. So we're going to need to tolerate some discomfort in the mental health system if we're going to do this and do it well. Tolerate the discomfort of being with and bearing witness to the terrible things that humans do to each other, but also tolerating the discomfort of the awareness of the harm we might have contributed to ourselves. Kind of a bitter pill to swallow for us as mental health services. And I take Warwick's point about not attacking or criticising anybody, and I think hopefully this approach is not pointing the finger, but it's more of a sitting with ourselves and wondering and questioning. But the advantage in being able to do that and being able to take our medicine in that sense is that we can then think of those other possibilities. I think if we take an event of seclusion, so if I worked today in a mental health inpatient unit, I'd be part of the implementation of seclusion and restraint practices. They're commonplace still, although many units are doing a fabulous job of reducing them. But if I kind of retreat into, look, it's in his best interest or in her best interest, it was so unsafe, there was no way to manage that, we reassure ourselves that was all okay, we leave it there. But if we sit with the discomfort and feeling like, I'm worried that this is doing harm, what else can we do? I don't know what else to do yet. What else can we do? So it opens up those possibilities if we can sit with it. So how are we going to make this change? I know we're to be talking a lot more about training and strategy and frameworks and policy, and I'd like to suggest that's the stuff that sits on the top of the water. Often used metaphor for service culture is it's the stuff that's below the surface. It's the stuff that the squirrels are doing. Deb, I was going to use the squirrel story. It's the stuff that happens below the surface, but it's the stuff that happens below the surface that sinks the ship, really. It sank the Titanic, didn't it? What was under the water. There's a recent study in the States in the Midwest with 100 mental health services looking at the implementation of new programs and initiatives. And no kidding, organisational culture had a major impact on how long those new initiatives were held for. They were held for twice as long in services that had as a core feature of their organisational culture a feature they described as holding the client's interests first. If the way that staff described the service culture was that it was taken for granted that we will put the client's well-being first at all times, those services held on to new initiatives, whatever they were, for much longer. Staff also stayed in services, so there was greater staff retention and satisfaction in services that had an engaged and functional climate. So the day-to-day working environment of services where that was stressful and staff were emotionally overwhelmed, no kidding, stuff left far more often. So if we're talking about offering trauma-informed care and then some trauma-specific services that are relationship-based, that means we're going to need to be able to hold on to staff in ways that are healthy and engaging. So it's a credit to your unit that so many staff have stayed for so long. Yeah. Okay, some other sort of, comments on culture. If we think about service culture as being the practices and the rituals that sit outside of policy, they're the things I think we're going to need to pay attention to as well. One of the services we did some training with last year revealed to us one of their cultural practices was a birthday day off. Everybody had a day off on their birthday, whether they liked it or not. And I don't think it was the day off that was so important, but in a staff of 20, that's more than one a month, people are having a day off. It was the ritual around, what are you going to do? What are you going to do to look after yourself? Have you booked it yet? How did it go? What did you do? How do you feel? So there was the ongoing conversations about self-care, which have become part of the culture of that organisation. So looking out for the practices that are outside of policy. We can have lots of policies, and in fact we do, about participation and consumer participation. But do we really value it? Do we seek it out well and outside of accreditation time and outside of policy requirements? Do we value it enough to really, is it part of our culture that this is what we do because it's what works and it's what's good for us and it makes sense. It's not about the policy, but we do it because it's good for all of us.